Welcome to Women Mastering Midlife, where we dive deep into the rich complexities of womanhood in our middle years. I'm your host, Victoria Byrd, a pharmacist, certified women's health coach, and your guide on this transformative journey. Whether you're navigating perimenopause, thriving in menopause, or mastering midlife's many transitions, this is your weekly dose of expert guidance, compassionate support, and a judgment-free space to explore it all. Here, we're empowering women to master midlife on their terms, reclaiming our health, our happiness, and our power. Together, we'll rewrite the narrative around this remarkable stage of life, from something to dread into a beautiful, bold transition. I'm so glad you're here. Hi there. So thank you so much for joining me today. I have Dr. Andrea Matsumura on the podcast today, and we are going to talk all things perimenopause, menopause, sleep. She is a board-certified sleep medicine specialist, internist, and certified menopause practitioner with the Menopause Society. She brings a unique, compassionate approach to midlife care by combining her clinical expertise in sleep science with a deep understanding of the hormonal transitions. We are going to get into all the things so that everyone listening can walk away with a toolkit so they can go to their doctor or their provider and say, this is what I heard on this podcast, and I want to talk about this with you. So thank you so much for coming on today. And we've already talked for about 20 minutes before I hit record. So I feel like I already know you. So I'm excited for the audience to get to know you too.
Thanks, Victoria. It's great to be here. I'm excited to have this conversation because it is needed.
Yeah, very much so. And I think that, there's a lot of people getting a lot of their information off of social media and Dr. Google about sleep. And everything's kind of all over the board. And some of it doesn't talk about women specifically. So I'm really excited to get into midlife women and all things sleep.
Yeah, me too. I mean, you brought up a good point that there's a lot of information on social media. And one of the things that we were just talking about was the fact that there's not a lot of research that's specific to women and specific to women and sleep in particular. So we're in this gray zone is what I like to say. And, I do use the evidence that is out there, but then I have to extrapolate some of that evidence and really tailor it to what women are saying and telling me and what they're feeling. And that isn't always in line with what the evidence is out there because we indeed are different.
Yes. And one of the things that we were talking about before I hit record was that even though there isn't the research data, because there's money that needs to go into it and time and all the things that are far beyond practicing medicine, just because there isn't the actual research data doesn't mean that you're not monitoring your patients, listening to your patients, making sure that what you're doing is safe and effective in a way that works for them.
Absolutely. There are these patterns that you start to see when you have enough patients, and I have had thousands of female patients come to see me about their sleep issues. And there are these patterns that bubble up that are consistent, that are really there's not enough research out there, and the evidence is not really solidified quite yet, but it's compelling that anecdotally I am seeing lots of patterns around inability to get to sleep and or stay asleep once perimenopause and menopause hit, and then the increase in the prevalence of obstructive sleep apnea in postmenopausal women.
Okay, so let's start with, for everyone out there who's in this midlife, in the thrux of midlife, how do the hormones start to come into play as our cycle gets all out of whack?
Well, so estrogen really helps with the thermal regulation. It helps with the thermostat of the body. So you'll hear women say that if they were having these perimenopausal symptoms and they started on menopause hormone therapy, that they feel better once they start on estrogen, and for the most part, I'd say around 2/3 of women that I see start to feel like they can sleep through the night because estrogen plays a role in the modulation of your thermostat, but also how it affects the regulation of melatonin. And so one of the things that I've come to find out in my research that's published is that melatonin and estrogen have a fairly intimate role with each other in how melatonin is produced. And as a sleep physician, melatonin is one of the big hormones that we think about when people can't get to sleep or stay asleep. So the estrogen really helps people stay asleep. Now, there have been a lot of in vitro studies, and there have been a lot of studies done on rats, but not a whole lot of studies on people, and really very few studies done on women around the regulation of melatonin and how estrogen plays that role. What we do know is that estrogen plays a role in the regulation of serotonin, which actually plays a role in the production of melatonin. So when you have a reduction in estrogen, you may have a reduction in serotonin, which then plays a part in the reduction of melatonin. Now, there's different data, though, that talks about actual estrogen receptors in rat models, that estrogen may, in fact, downregulate melatonin. So what this tells me is that we don't have evidence or science that tells us whether or not the addition of estrogen is helping melatonin production or reducing it. But what I can say is that in my patients that are on estrogen and progesterone or estrogen alone and continue to have sleep problems, and we've eliminated any other organic medical condition, if they start on melatonin, they tend to have more success with maintaining their sleep.
Okay, so melatonin is one of those things that you hear everybody talking about, that they chew melatonin gummies every night before they go to sleep. And a lot of people don't really understand how it works.
Right? Yeah. So melatonin works in our body. It is a circadian rhythm regulator. So circadian rhythm is basically the cue for when your body needs to get up for the day versus the cue for when your body needs to go to sleep. And every cell in our body is on a circadian rhythm. So it's really important to get quality sleep, regardless of how much you're getting, because there's also that whole notion that you must absolutely get 7 to 9 hours of sleep. Yes, while that is optimal, even if you're getting 6 hours of sleep, if you're getting 6 bad hours of sleep, that's really bad. If you're getting at least 6 good hours of sleep, that takes you a long way. So when we talk about melatonin, it is actually released from the pineal gland around 4 hours before you actually go to sleep. So it is a clock starter. It is not a sleep aid. It is not supposed to be taken right at bedtime to help you fall asleep. So as melatonin rises up in your body, then you get sleepy enough, you fall asleep, it is sustained and elevated throughout the night, and then it washes out, and that's when we're waking up in the morning. So that's how melatonin works in the body. And the pineal gland is one of the first glands in our body to start to calcify. So then we have this reduction in melatonin production up to 50% by the time we are 50. So I'm going to say something very bold and probably not popular at this point because we don't have enough evidence or research out there. But I am convinced that melatonin is going to be the next vitamin D. It is going to be this hormone that we did not realize we really need because it plays a role in aging. And yes, some people say, well, this is just part of the normal aging process. And I don't refute that. However, I want to have high quality aging. I'm not really interested in extending my life if it's low quality. I want, and this is what I tell my patients, my job is to maintain the highest quality for your life for as long as you're on this planet. So, it doesn't feel good if you have a pretty low quality of life, but you're still alive, right? And you can't do all the things that you want it to do. So melatonin has this role in mitigating oxidative stress on the body. And we know that oxidative stress on our cells is what advances the aging process. And then organs, hormonal systems, they then do not run as efficiently which then leads to all of this. But what this translates to for me is that a lot of people who are 50 and up will come in and say, well, I'm older. I'm not supposed to get good sleep. And that's actually a fallacy.
Yeah. I mean, I would rather live not having the last 5-7 years of my life in a nursing home, decrepit, needing, assistance to go to the bathroom. That doesn't sound fun to me. So of course I want to know what I can do to enhance my lifespan and my health span.
Right. Exactly. And so I really think that not only is, and I've said this before, that estrogen and progesterone are part of our life force. They're part of our just, who we are, our makeup. And that when we begin to lose this for the second half of our life, that we do need to replace it if we can. But in addition, the hormone melatonin may play a bigger role. And there's a lot of fear mongering around the use of melatonin. And then there's mass production of melatonin with a variety of, how well it works, a variety of efficacy out, on shelves right now. And so, I would like to say that, one of these days we can kind of land on everybody should take this low dose, just like we've landed on vitamin D. Everybody should take this dose of vitamin D, and here are all the things that it helps. Well, I think that melatonin is that for the future of our health span and lifespan, that melatonin may play a key role in helping us maintain that quality of life.
Yeah, well, I was of the thought, based on what I had read, that you really want to limit when you take melatonin, either for travel or whatnot, because if you do take it regularly, your body will stop making it.
Yeah, that's not true. So that's been debunked. And there are actually published studies that say that. So that's something I can actually say is evidence-based, that taking melatonin does not mean that your body's going to stop producing melatonin. But we do have a reduction in our production of melatonin. So replacing it may in fact help our quality of life, because as a sleep medicine physician, I am going to be biased probably when I say this, but sleep is the juggernaut. If you're not getting the quality sleep that you need, then everything else in your body just isn't going to be as well managed as it could be.
Oh yeah. I tell women all the time, it's the base of your pyramid. I mean, because if you're not sleeping well, you don't want to exercise, you're making poor choices with what you eat, you're not mitigating your stress, you're not getting out there and being social and active and doing all the things that your brain needs you to keep doing. So it really does lay the foundation for your everyday life.
Yes, I tell my patients that when we sleep, every organ and gland in our body is set to this circadian rhythm, and there are certain organs in the body that need to get into sleep mode. And if we do not have quality sleep and we don't get into the right stages of sleep, then those organs cannot get into sleep mode. And then the little, boutiques is what I call them, like the little glands or the other organs that might need to work in a different way when we're sleeping, can't function optimally because the other organs are working hard. And so your body's kind of thinking, am I awake? Am I asleep? What mode am I supposed to be in? And so then everything is a little bit off.
Yeah, and that kind of leads me to my next question. How often do you find that the sleep troubles lead to chronic conditions?
Well, there is a lot of data actually that is out there that shows that it's not a true cause and effect, but there's an increase in risk for certain cancers. There's an increased risk for dementia when you have chronic insomnia. There's an increased risk for pulmonary hypertension if you have a breathing disorder, as well as heart attacks and strokes. So it's really imperative that women make sure that they don't have an organic breathing disorder that is causing their sleeplessness. So once we, do all of the things and land in the space where maybe somebody can replace estrogen and progesterone and they continue to have problems with their sleep, they really need to look at all of these other causes that could be affecting their sleep because they can have consequences related to chronic medical conditions.
Okay. So we talked a little bit before I hit record about sleep apnea and how in the sleep medicine world, it kind of, if it doesn't fall into sleep apnea, it doesn't matter. It's like, oh, well, too bad. But I do want to touch on sleep apnea a little bit because I'm not as well versed in sleep apnea as I probably should be. I know many family members that have their CPAPs, but I don't really understand the mechanism of sleep apnea, and especially in like a milder case where it's not that like down the hall I can hear somebody stop snore breathing, you know, those scary people that live down the hall, but there's more subtle sleep apnea problems.
Yes. So in women, because all the data that is out there and what our screening tools are based on are men's symptoms. So a very common screening tool, stop bang, the last question is gender. So if you're a man or a woman, so you lose a point if you are not a man. And that, I am sure there are a lot of women then that do not fall into the high risk or moderate risk category, and then they are not tested. So we are not catching women who have sleep apnea because we don't have any great screening tools, and it's not thought of as a condition that affects women. But it indeed does. 1 in 5 women have sleep apnea, postmenopausal women, and 90% of them do not know that they have it. And that's because women present with fatigue, with insomnia, with depression or mood changes. They don't present with the loud snoring, the witnessed apneas. You know, they also feel tired during the day, which is in the sleep world, people will say, well, there's a difference between feeling tired or fatigued versus truly feeling sleepy. And so then this is where I think that biopsychosocial model doesn't do women any favors, because women have learned to, you know, overcome their daytime sleepiness because we have all of these, you know, the minutia of responsibility that women have, the mental load that they carry in their households plays a role where, you know, I always say in my practice, truck drivers and women never say that they're sleepy because we have learned how to compensate so well for it. So women present differently with sleep apnea, and then they tend to have, it's not absolute, but many women will have what I call, or what is called and has been studied, REM related sleep apnea. So we have 4 stages of sleep, stage N1, N2, N3, which is a slow wave sleep, and then REM sleep. REM sleep is when we're dreaming. So when we're dreaming, we have no muscle tone, but our brain is very active. It's almost like we're awake on some level. And so then we lose our muscle tone. And so if we already have some closure back here because we're relaxed, but then if we have a tendency to have sleep apnea, then we really close off this airway during REM sleep. This pattern happens with women. So the traditional, you know, diagnosis of obstructive sleep apnea, I really think that women have a different phenotype. And so phenotype is they have a different kind of sleep apnea that has yet to really be thoroughly evaluated and discovered. So then home sleep testing misses a lot of mild to low moderate sleep apnea in women. And this is anecdotal because no sleep testing company is going to say that they have a high false negative rate in women. But I have found in the years that I've practiced, when I do home sleep studies on women, they tend to come back negative, and then I put them in the sleep center. I do a different kind of sleep study, which is between an in the sleep center sleep study and a home sleep study. It's called a type 2 home sleep study. I will capture sleep apnea. Now, a lot of women have barriers to wanting to be tested because they think CPAP equals Darth Vader. And they do not, and they do not want a CPAP, but there are other options out there for treatment.
If you're navigating the maze of perimenopause and wondering, is this normal? You're not alone. My free guide, Menopause Science and Symptoms, breaks down what's happening in your body and why. It's your roadmap to understanding the changes and embracing this phase with confidence. Download it now at missvictoriabyrd.com/free guides and take the first step toward empowered wellness. You'll also find the link in our show notes below. Be sure to sign up and grab that free guide. So you don't have to don the mask and carry the suitcase with you whenever you travel.
Not always. And I'm finding that for many women, by and large, who, are trying to take care of their health, who don't have any chronic heart or lung condition, or who don't have a musculoskeletal condition, that they can get away with using other options that are out there. But, the sleep community tends to not focus on the other options, because the long and the short of it is that insurance companies don't cover that.
Yeah.
Insurance companies cover CPAP. And so then we tend to blanket, prescribe CPAP for everyone. But, CPAP machines were made for guys. And most masks are made for men. Putting some purple butterflies on them or making them pink doesn't mean that it's going to fit my face.
I love that. It's like pink weights in the gym. Really?
Yeah.
Is it going to help me lift any better if they're pink or purple? Or they have little flowers on them?
Exactly. So I find that women who have mild sleep apnea might do really well with an oral appliance. Oral appliances are not covered. It's variable. That's what I will say. Some insurance companies will cover oral appliances, some don't. And then if they do cover oral appliances, they tend to cover only one type. And, again, that is not personalizing treatment. And there are some oral appliances out there. There's a whole bunch. There's at least 20 to 25 on the market. But there are a couple that I think are really useful for women. They're small, they're malleable, they're lightweight, and they can work out just fine for the treatment of mild to low moderate simple sleep apnea for women. And you don't have to use a big CPAP. So that's not a popular option if you go to a traditional sleep medicine office. But, I'm here because my focus is on women and sleep. And I think we have to do things a little bit differently.
And so that you came up with the D.R.E.A.M sleep method. It's D.R.E.A.M.
Yeah.
Well, I'll put those in the show notes so people can see the whole thing. But explain that to me, because I think that it's so refreshing to hear that there are some specific things for women to figure their health out.
Yeah, definitely. So the D.R.E.A.M method is an acronym for daily activities. So what are we doing in our day that might be infiltrating our sleep? Let's examine all of that. Take a look at that. R stands for your resting environment. Is your resting environment conducive to allowing you to relax, disengage, and get to sleep? E is for our emotions. There is no doubt that there is more anxiety and depression in our society, and it disproportionately affects women for a whole host of reasons. And then A stands for archetype. So I developed this. It's circadian rhythms, whether or not you're an early bird, a night owl, or you fall into societal norm. But I name them. Athena is if you fall into societal norm. Artemis is if you are an early bird, and an Aphrodite is if you're a night owl. And that's because my brand is Sleep Goddess MD, because I want everyone to sleep like a goddess.
I need to learn how to sleep like a goddess.
and I thought it would be fun to have Greek mythology female heroes be part of the circadian rhythm archetypes. So that's the A. And then M is for all of the medical conditions. So do we have sleep disordered breathing? Do we have restless leg syndrome? Do we have chronic insomnia? Do we have a hormone imbalance? Whether or not that be estrogen, progesterone, thyroid, insulin. I mean, let's fix it, right? Do we have pain that's affecting our sleep? Do we have trauma that's affecting our sleep? There's so many different, do we have medications that are causing, sleep changes that we don't even really know about? There are some medications that actually cause insomnia, and we don't even realize that they're causing insomnia until a person like myself starts getting into, everyone's history.
Yeah, it sounds like you definitely take a big, broad picture look at everything, but also like going through it with like little toothpicks, trying to figure out all the nitty gritty.
Yeah, definitely, because sleep it's not rocket science, but it is complex, and lots of things affect sleep that we don't really think about. So yeah, that's why I decided I'm going to provide this comprehensive approach and make sure that we don't leave any stone unturned, and that we pull all the levers, because if you only focus on one, then you're not going to get very far.
Yeah, I when I talk with women about sleep, we back up and talk about the hours leading up to it. And for a lot of women, they're running, they're cleaning up the kitchen after dinner, they're doing the homework, filling out the forms for the next day, getting everything ready for the next day ahead. And then they get into bed and they think they're going to fall asleep because they're tired. But then they're all wired and they can't figure out why they can't fall asleep. And so I think looking at broad stroke, like what does the day look like, is a great way to start.
Yes, because many women do take on all of that mental load in the household, and they don't give themselves or allow themselves to have this time where you start to relax and prepare yourself for sleep. And when you look at everybody else in your home, you've done that for everybody else.
Yes. I know, especially when when I had little kids, sleep time was a non-negotiable. We had the routine, and anytime there was a deviation in the routine, their sleep was a nightmare, which then set a couple days forward just in disarray. So, but we don't think about it for ourselves.
Right. Yeah. Women are used to putting themselves last, and this gives us the opportunity to put yourself first. So that's what I say when I see my patients, is that this is your opportunity to put you first, to invest the time and energy to help you live the rest of your years the way that you want to. And I'm saying that because a lot of women come to me with the presenting symptom of insomnia, and they have developed some elaborate, methods to help try to get them to sleep, but it's not really working. And sometimes people have this fear of letting go whatever they're doing. And I have to say to people, I understand, and you're here because it's not working.
Yeah.
So let's think outside of the box. And just like it took a long time for you to get here, it might take a little bit of work for you to get back to a better place where you're confident in your ability to get to sleep and stay asleep. However, we're setting the stage for the rest of your decades of life. So maybe 6 months of a little bit of dismantling, rewiring of the brain, it's going to set you up for success for the rest of the decades that you're here on this planet. And that can mean many different things, because one of the things that I also say is that I rarely see anybody with one sleep disorder. So that's why I developed the D.R.E.A.M sleep method, because it helps me catch all of the things that are all of the diagnoses that are affecting somebody's health. And once we are able to tackle all of the pieces, then that really helps somebody achieve and develop that confidence that they can get to sleep, and not look at the evening and getting to bed with fear and anxiety and having all this anticipatory anxiety that they're going to have to struggle to just get the few hours that they need to get up and, do the same thing the next day.
Yeah. Well, and any female who has slept in a bed with a male, it is so infuriating that they can just roll over and go to sleep. Mm-hmm. And they can get up in the middle of the night to go to the bathroom and they roll right back over and go to sleep. It's just amazing to me. And it's infuriating, but also it shows that even is such a difference between men and women.
Right. And I go back to that biopsychosocial model, that it's probably multifactorial why they have that ability to go right back to sleep or fall asleep easily. And it goes back to that mental load, plus the fact that there's a whole lot more data around men and what might be the triggers for abnormal breathing and sleep versus women. And so there's just a whole host of factors, the societal pressures, the fact that, like we were talking before we hit record, the fact that we've normalized the suffering of women through every decade of life. So that alone is a huge burden to carry. And, when we go to sleep, this is why sometimes we have trouble sleeping. It can be one of the many reasons. We don't have anything distracting us. Most of us are, we get up and we are present for the day, present for everyone else, and we're doing all of these other things. We don't have the time to really think about our own needs and what might be driving that insomnia. And then when you go to bed, it's just you and no outside distractions. And that's when things bubble up, and then we have trouble getting to sleep for many different reasons.
Yeah, I would say, if I was asked, how'd you sleep last night? It's like, well, I didn't sleep, but I thought all about all of the world problems last night.
Yeah, really common.
That's good to know. So as far as treatments are concerned, we talked a little bit about melatonin, but it sounds like your approach to melatonin is different than go to the drugstore, grab a bottle, and chew a gummy right before you go to sleep.
Yes. So, sometimes you want to take melatonin to help with your circadian rhythm if you are having trouble getting to sleep and staying asleep. And it may be part of the plan if you have been diagnosed with chronic insomnia. But I think that potentially it may have use just generally. Like I generally take vitamin D every day. Just full disclosure, I also generally take melatonin every day. But again, I take it about 2 hours before I'm going to go to sleep. And the data that's out there is showing that sustained release melatonin is much more in line with our own general physiology. So a lot of people, and then anecdotally, in the years that I've been practicing, people have said, well, I take melatonin and it helps me get to sleep, but it's not helping me stay asleep. So that sustained release is more in line with keeping levels elevated so that we can stay asleep. I'm not going to say that everybody should take it, but there's just a lot of fear mongering around melatonin, and there's a lot of disinformation, and there's a lot of unknown. So before we come out and say, everybody should take melatonin, it's worth exploring and discovering if your body does better with a little bit of melatonin, anywhere between 1 and 3 milligrams sustained release around 1 to 2 hours before you go to bed. You don't really want to take it at bedtime. That's not how it works in our body. Now, that's for folks who want to get to sleep and stay asleep, and they're following their circadian rhythm. We also use melatonin as a circadian realignment therapy. So a person who has to wake up really early, but they're a night owl, we help them advance their clock so that they can go to bed earlier. And we use it in a very different way, in a different dose. So there's different ways. It's complicated, right? It's not complicated, but I would say it's more complex than what is out there on the internet.
Okay, so that makes sense. And I think what's interesting is there's a stigma around melatonin. But then my experience when I went to the doctor and was complaining about my sleep and how I would wake up in the middle of the night, soaking wet, all the things. But I was too young to be in menopause, which wasn't like, yes, I'm not in menopause. I know that. And I was given a prescription for trazodone for my sleep. And so I wasn't given hormones, and I was given trazodone. So I thought, I found a new prescriber, by the way. I'm seeing a different doctor. But I think, why is that the answer? How are we stigmatizing something that naturally occurs in our body, which also then falls in line with estrogen and progesterone and testosterone? And we're medicating with Ambien, trazodone, and all of those things.
Yeah, I am not a fan of any of the prescription medications for sleep because they're filling receptors, but they're not necessarily getting you into the right sleep stages. And that's really what we want to accomplish. And with the advent of everyone using a wearable, which is anything that you have on your body that is recording sleep, right?
Yeah.
Then we start to focus on, well, what is light sleep? What's deep sleep? What's REM sleep? And I usually tell folks, all of the wearables that are out on the market, they're not diagnostic. They have not hit the accuracy rate where they can be truly a diagnostic tool. But they do help with trends and patterns. Mm-hmm. And so if you notice a big shift in your sleep stages with your wearable, then that's something for you to say, maybe I need to go back and take, and have a conversation with my healthcare provider about that. But yeah, melatonin, I am again it's probably going to be the sword that I die on. The other thing that I wanted to bring up, because you kind of touched on this with your question, is that there's different camps. So certain specialties will say, absolutely not. Melatonin, I don't know what you're talking about those. And then there's certain specialties that say, no, absolutely, we should be using it. So when we think about sleep medicine physicians, historically, it's either been a psychiatrist, a neurologist, a pulmonologist, or an internist. And I'm in internal medicine, so I like to say I'm agnostic to all of those other specialties. And so the three pulmonologists, and these are generalities, pulmonologists will say, I'm only focusing on the breathing part. I'm not really going to focus on the other components of sleep. Psychiatrists will talk more about sleep stages and how sleep can affect mental health. And then neurologists, there's two camps. I've met neurologists who say that there are chemical imbalances in the brain and hormonal imbalances, and will be huge proponents of using melatonin. And then I have friends who are neurologists that say, absolutely not. We should not use anything. There are no chemical imbalances that affect sleep. This is all other types of physiology. So, there's a lot of disagreement within the medical community, within the sleep physician specialty, around what melatonin is, how we should use it, and its indications.
Yeah, I'm beginning to get the feeling that there's disruption in medicine as a whole, going away from this is the guidelines, this is what you were taught, this is what you should say, and this is what you should do. And if anybody is an outlier to that, it's like, too bad. Oh, well, they just can't be helped. And now we're looking at it as, disrupting it and taking a look at these are some options. And what you're seeing on the ground, boots on the ground, you're seeing patients, you're not just in a lab, you're figuring out what's working for women, for them in particular. And what might work for me may not even work for one of your other patients. So that's causing, that's creating more of it's niche medicine without it being, I don't even know how to describe it. Do you have a good word for it?
I say that we're coming back to the art of medicine. Okay. Because when we treat a patient, when I see a woman that's in front of me, that's her own personal story. That's her own body. And I am going to tailor her treatment plan for her needs. Now, we had moved away from that, and that's a whole nother podcast, right? Around the corporatization of medicine and how the algorithms came into play, right? I like to say that I am coming full circle and coming back to the whole concept of the art of medicine and really individualizing treatment for each patient.
That's the way it should be, because, from my days in retail pharmacy, just handing a big giant brown paper bag to somebody, it shouldn't be the answer.
Right.
We should be breaking down the whys behind the need for all of that and figuring out what we can do to eliminate some of it instead of just putting a pill down somebody's throat.
Yes. And, there's so many permutations of that, right? Like, we know there are certain infections and it's just really straightforward. You take this antibiotic you get rid of this infection. But then there are so many other parts of medicine that we just don't really know about all that well. There's not that much evidence because there hasn't been enough funding and research for some of the, I don't even know how to say it, like some of the other medical conditions. Well, one thing that we can say is medical conditions that affect women more than men. There really hasn't been enough funding and research for that field, right? And so that's why you and I both are passionate about helping women in midlife, because we have all this new data, this new information, and we want to change the way that we are affecting women's lives, because we want to bring that new data forward and allow people to understand what all the options are when we really, I was that young doctor taking women off of their hormones, and I've forgiven myself and made peace with that. And, and then I hit menopause, and I had my own menopause story where I had to go to 4 different physicians before I found somebody who actually connected all the dots and said, oh, you need hormones. So, we're just not taught. We're not taught this information.
Yeah. I graduated pharmacy school in 2004. I was like a million years ago. But I was in school, I worked in a pharmacy from the age of 16, so 96 on. So I saw hormones coming through the pharmacy, and then I saw them dying on a shelf. And I always, you don't question. It's a big study. It made headlines. It scared everyone. And that was just the way it was. And so when you know better, you do better. And I think that now that we've seen why the data presented the way it does, and seeing how there were still doctors giving hormones, and those patients were still thriving and doing okay. And so now we're changing the narrative, which is fantastic. But I was thinking, when you were talking about antibiotics and a virus, or not a virus, a bacteria, I remember drugs and bugs. They were flashcards. Like, it was literally, this is the bug, this is the drug you treat, and that was so easy, very simple. A equals B. But when you get into the therapeutic diagnostics and figuring out a plan of medications for people, it is a lot more complicated than just a drug and a bug. But I think we also miss the mark with lifestyle choices, and with your method of being able to say, let's take a look at your life, everything, your daily activities, your mental load, and even just the type of morning person, evening person you are. Those are some things that we were definitely not taught back in the day.
Right. We weren't taught that. And then the corporatization of medicine has distilled it to, I have 5 minutes, and this is the, 3 things I'm going to focus on. You don't have these 3 symptoms. Okay, bye. We have lost the holistic approach to treating people. Yeah. And it's terrible. We treat disease. We don't treat people. And so I like to think that my approach is going back to treating the whole person, being holistic, being comprehensive, and addressing lifestyle choices, addressing external factors that could be contributing to the decision-making around your lifestyle choices, and helping people really help themselves, and learning about how their body works in general. Like, we also don't do a good job of really helping people understand why they're taking what they're taking, or why they're doing something in their life and how it impacts their health.
Yeah. So in closing, if we wrap up this conversation in a tight little bow, the hill you would die on, we've talked about that. Yeah. What do you think, what would you like to see moving forward for women's health in the sleep world?
Yes. So what I would like to see is, and I am in the process of spearheading this, is developing a good screening tool for women and sleep disordered breathing. I'd like to be able to see people take more of a holistic approach to women's health, and to use the evidence that we have out there as your base, but don't be afraid to think outside of the box a little bit and tailor treatment for women particularly midlife women who have increased risk and other types of sleep disorders. And, those are kind of my three biggies, is to really promote the fact that sleep, again, is the core, and that we really have to get back to helping ourselves achieve high quality sleep to improve the quality of our life for as long as we are here on this planet.
I have learned so much today. I'm gonna go get some extended release melatonin for my house, and I'll save the trazodone for the dogs when they have trouble sleeping. Yes, but thank you so much for coming on, and I'll put in the show notes ways for everyone to find you and connect with you. And I'm just selfishly, this is why I do this. I appreciate letting other people hear our conversations, but selfishly, I have a reason to ask people to talk to me about their things, and I love it. So thank you so much for talking with me today.
Oh, you're welcome, and thanks for having me.
Thank you for listening to this episode of Women Mastering Midlife. If something you heard today resonated, I'd be so grateful if you'd share it with a friend who might need a little extra support on her midlife journey. Remember, small changes can make a big difference, and you don't have to navigate this transition alone. We will be back next week with more expert guidance and compassionate conversations to help empower you to master midlife on your terms. Until then, you can find us on Instagram at Women Mastering Midlife, or come connect with me directly at Miss Victoria Byrd. And you're looking for deeper connection and support, be sure to join us in the Women Mastering Midlife community. We'd love to continue the conversation with you there. If you've enjoyed this episode, please rate and review this podcast. It helps us reach more amazing women mastering midlife just like you. You'll find all the links from today's episode and ways to connect in the show notes below. See you next time.